Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site.
Hi, welcome back to Unraveled, Understanding Chronic and Complex Illness. I'm Eileen Ruhoy, neurologist.
David Kaufman,
I'm with
internal
David
medicine,
Kaufman.
whatever else I am, I don't know anymore.
And so David and I, every time we chat, we can't help but sort of talk about our chronic illness patients. And we talk about, the joys and the lows and the highs and the disappointments and the discontent and the feeling like we want to just get them all well. And apropos, there was a recent workshop, and it was called Toward a Common Research Agenda in Infection Associated Chronic Illnesses, a workshop to examine common overlapping clinical and biological factors. I think I used the wrong intonation in reading that long title out. It was done by the National Academies of Sciences, Engineering, and Medicine, and there were a lot of scientists and doctors involved that both you and I know well. And we read the proceedings, and it just sort of seemed like we just wanted to have one of our usual conversations in more depth on our podcast, because I think that our subscribers would really appreciate some of this insight that's going on, largely because of the long COVID world right now.
Right.
And I think that's what prompted this particular workshop that was held. And but we said, like, wow, they mentioned MECFS, which is pretty amazing. And then you were bringing up the fact that that maybe we call chronic Lyme long Lyme, and I love that idea.
Right.
Like,
well, it was in that report. Somebody used that term. And
I didn't pick that.
Yeah, it was in there, and I thought that
was
it was great because it links it to long COVID, so it gives it a little bit more respectability.
Right. No,
because,
exactly.
the academic world has been so down on chronic Lyme.
Right. And I said to you that, long before I sort of entered this world of chronic and complex illness, I didn't really believe that chronic Lyme existed, not because not because I had disbelief in it, just because I didn't know what it was about. And of course, in the neurology world, chronic Lyme is not a thing. Certainly wasn't, for years. I think they're starting to make a little bit of headway, but certainly not enough. And, I think I've mentioned that, I think 5 years ago, I went to the annual neurology conference, and there was a whole talk about why chronic Lyme doesn't exist. So so it's just, and now that I've been in this world, I'm like, well, clearly it exists. I mean, there's not only literature, but I've seen lots of patients with chronic Lyme with biomarkers, with symptoms that are consistent with. And anyway, so it's just sort of, it baffles me, as I've said, so that we struggle so hard to try to gain acceptance for, and it's not for me, it's for the patients, right? Because that's why they're gaslit so often, and that's why they're invalidated so often, and that's why they feel like they're just orphans of our healthcare system, because they go see doctors who just don't believe them and don't even want to begin to try to help them or understand them. And so, that, so I was really excited about this workshop and reading the proceedings. There's a lot of great research, a lot of great information, again, housed in the long COVID research, but certainly applies to other chronic and complex illness.
Yeah, I think so. A few quick introductory things to say about it. So it was very exciting to see that they set this workshop up. And I read most of what you sent me, which is this enormously long review of all the topics that were covered.
Right.
And there were a lot of heavy hitters there, both academic heavy hitters, which have their own world and their own silo, and then some of the chronic Lyme, chronic fatigue syndrome researchers and doctors who I have a huge amount of respect for, who really know their stuff and have been doing this a long time. So, the first thing to say is, this is a terrible thing to say in a way, but thank God for long COVID, because finally we're getting visibility to this problem. This is not a new problem. So in one hand, we could say, been there, done that. There was nothing new. There was nothing new in this 100-page review that you sent me, or however many pages it was. You and I and others have been talking about all of this information for years and years and years. Literally, probably 20 years, people have discussed this issue, and it's just fallen on mostly deaf ears. Mm-hmm. So because of COVID and the numbers, suddenly the academic, regulatory, NIH world is waking up, and there's a good reason. There are estimated 16 million people with long COVID, 2.5 million estimated with MECFS, and I think one of the speakers estimated that costs the country $500 billion a year. So that's when people start to wake up finally. So in that sense, it's great news. As I sort of said, and as you said, not much new in there. There's some pieces of new science and new research, which is great. What's really new is that people are thinking about it finally and starting to make some linkages. And even there was couple of paragraphs in there where they acknowledge the issue of silos that you and I have talked about, and how part of the problem has been that medicine has operated in silos, and therefore we just don't acknowledge or recognize this. It's a little bit like the old elephant image where you have people blindfolded, and you have an elephant, and one guy says, "Oh, there's a tail," and no, there's no tail, there's a foot, but nobody knows it's an elephant. Okay,
Yeah.
So hopefully the elephant will finally come into the room and people will open their eyes, and we'll see how it goes. But it was good to see, but I'll wait and see.
Well, and it's
also.
always good to see a collaboration of physicians and scientists of different specialties, different perspectives, different backgrounds, because that's what will solve this problem, right? Because very often, you go to see a particular specialist and then it's outside of their realm and they say, well, that's not me, you have to go see someone else. And so then patients go, they're just sort of shuffled around. And so it's nice to sort of see collaborative efforts like this on diseases that clearly affect almost every organ system.
Right.
And I think that's where and I think a lot of it, they focused a lot on what is the pathophysiology behind this. So is it viral persistence? Is this post-infectious? But, so this is not in the proceedings, but I know that there's been controversy over how to label these kinds of diseases. Like, is it post-infectious, which would imply that the infection is over, but there's a whole faction of people that believe that there's still persistent infection. So is it persistent infection? Is it a fragment of the virus that still is creating problems and an immune response elsewhere? So it's not the complete virus, so it's a different kind of infection. Right. Or is this truly just a post-immune response? I mean, I think it's a little bit of everything.
So I think the answer is yes.
All of the above.
Yes, it's all of the above. We don't really know, and it probably is. In some patients, it is all of the above, and in others it's just persistence, and in others it's autoimmune, and in others it's some new problem that's been unmasked by the previous illness. So in the same way that EBV reactivates in COVID, and that may drive a second phase of the illness.
Right, that's the other, so that was the other potential pathophysiology. Is there a reactivation of viruses that are already present and just have been dormant?
Right.
So
and that's the beauty, actually, the more I think about it, of the term long COVID, and what I love, again, is long Lyme. It basically admits we don't know shit. We don't understand what is causing it, but at least we are recognizing that there is an illness here. So that's a huge step. Maybe we should change MECFS to long fatigue. I don't know.
Right. Well, I mean, the research shows that any patient with, let's take long COVID, because that's where a lot of research, at least recent research, really has sort of resided, is that it shows that there's a greater risk of autoimmune disease. Yeah. There's a greater risk of neuroinflammatory response, and they're showing that there's, glutamatergic dysfunction. So there's, not only glial activation, but astroglial activation. And so it shows microbiome alterations. For sure.
There was a really good section on microbiome.
Yes,
which was really excellent.
And the microbiome itself, of course, is implicated in a lot of other connections in terms of the immune system, in terms of the nervous system. Right. There's a significant dysautonomia that comes with these post-viral illnesses, long COVID, MECFS, long Lyme. We'll just call it long Lyme, you and I. That'll be our term. And I think that's all real important, because I think it starts to lend itself to sort of realize, like, okay, these things are happening to a patient's body after this viral illness, which, by all accounts, it's a mild illness for most patients. These aren't necessarily hospitalized or severely affected patients by COVID or EBV, if we're going to use that as one of the viruses that lends itself to MECFS. It's like it just sort of came and went. No one really thought about it. It was just another illness in their lives, and yet years, and oftentimes it'll crop up years later, where the symptoms of MECFS, for example. And so it shows that it doesn't have to be immediately post-viral. It doesn't even have to be a few weeks or a few months later post-viral. It could sometimes be a couple of years if these
I
sort of
think
rear its ugly head.
in fairness to the healthcare system, and I know that I'm often very critical,
Mhm.
because of those delays, it's just not obvious. It's not easy to figure it out.
No, it's not.
And given all the constraints on our healthcare system and our doctors and time, all the stuff we've talked about a lot of times, in insurance industry, et cetera, one can understand why it is taking so long to get a handle on this. I think we're sort of at a tipping point or inflection point, partly because of long COVID and the devastating numbers of people who are suffering from this, and partly because there are some graphs in that report showing this enormous spike in these chronic infection-mediated illnesses and autoimmune disease, and they're all linked together. And we've touched on that previously in terms of the changes in hygiene hypothesis and stuff like that. But at the end of the day, regardless of which theory one believes in, which hypothesis, the fact is that then the spike in autoimmune disease and post-infectious diseases is enormous. And I think finally it will have its day in the sunlight, and we'll get some real research and progress off this.
I think the autoimmune component is particularly concerning, because once the body starts attacking itself, like, where will it end, right? So, and that's the basic definition of autoimmune disorders, and even learned that in medical school. The body just turns on itself and starts attacking itself. I think it's a lot more complicated than people realize. If there is an antibody against the receptor, as we know, receptors have multiple parts to it. There's multiple components, and there could be an antibody against any particular component, which can change the receptor in a myriad of ways. It's not just about blocking a receptor, or it could change the function of the receptor. It can change the intracellular signaling of the receptor. It can change a whole lot of things about how the ligand fits with the receptor, and so on. So I really do think that the autoimmune component is most concerning in many respects, and it's sort of what I try to focus in on with patients. I'm not in infectious disease as you are. I don't really understand the antibiotics that are used as you do. So I just sort of focus from the immune system, and we do a lot of mast cell activation, which of course is the part of the innate immune system, which is the first responders. And so we work a lot against the mast cells. We try to stabilize them. We try to counteract some of their mediators. But then I say, eventually, if the mast cells have been active for so long, then you have the adaptive immune system, which now you are creating all these antibodies. And then we've talked about this, but I use a lot of immunomodulators. I start with the more basic kinds like IVIG and plasmapheresis for sure, but if patients don't get better enough and faster, then I start to add on immunosuppressants just to try to sort of tamper down that adaptive immune response, which I think really creates a lot of problems, because once you don't have the basic ability to sort of maintain homeostatic mechanisms because the body's attacking itself, then I don't know where a body goes, or a brain goes for that matter. I think that's behind a lot of cognitive concerns and brain fog. And so I really do think the autoimmune component should be focused in on more, which, autoimmune really, to me, autoimmune, every specialty owns it, right? Because in every specialty there's an autoimmune disorder.
Exactly.
And it's interesting that they actually included MS in the proceedings. And I mean, one of my comments was really just sort of like, well, I don't know if MS yet is, it was in the list of, long COVID, MECFS, and there was a couple of others on the list that were post-infectious, but they called MS, which, yes, there's lots of really strong data to suggest that a viral illness can lead to MS, but there are clear defining criteria to diagnose MS, which does not exist for things like, and I know we have criteria, but I don't think that they're clear and defining for MECFS.
We don't have
and
biomarkers and imaging markers for these other problems.
So I think they're sort of in a little bit worlds apart in that regard. But it is interesting that they're at least acknowledging that MS now is thought to be a post-viral illness.
Right. So, one of the things that occurred to me, I was reading this morning, so it's still reasonably fresh in my old mind. And I'm biased when I say this, but if you read this report that you sent me through the perspective, through the lens of septad, it's pretty amazing, because the septad concept is just on page after page after page.
Yeah.
They don't know that. I mean, and that's not a criticism. They don't have that that model. But it just shows once again to me how powerful that model is to understand how this crosses the silos and knocks them down and helps to understand the pathology that's occurring
Right.
as a result of infection. Another takeaway for me in reading this, or maybe it's that it just brought it to mind, is these post-infectious illnesses, post-infectious chronic illness, don't happen in a vacuum in each patient. Almost every time, if you go deeply enough into the patient's history, there are hints in that person's history that say this person will be at risk. And I think we've said this, or I've said this before. I don't think I've had literally one long COVID patient who I could not find a risk factor for. They didn't have a hint of mast cell or a hint of long-standing SIBO, a hint of leaky gut. Whereas every other patient has those things if you ask enough questions and listen to them carefully. And that's a theme throughout medicine, but it's often been ignored or not fully understood in these post-infectious chronic illnesses. It also reminded me of something. I was at a conference in pre-COVID in Lisbon, I think, on autoimmunity. It was an incredible conference. And, one of the takeaways was, well, obviously that there are vaccine reactions. This was pre-COVID, so nobody got up and shot the guy for saying that. Mm-hmm. And then they went through the risk factors for that. And time after time after time, family history of autoimmune disease, be careful with your vaccines, okay? And at that time, it wasn't as much heresy as it is now to say that, but I think it's absolutely true.
Absolutely.
And, we need to recognize that. That doesn't mean we're an anti-vaccine doctor or person. Yeah. So now I will routinely counsel patients if there's a history of autoimmune to be cautious and routinely say, there's no reason you have to get 4 vaccines in one day, right, or even 2. So COVID and flu.
And RSV now.
Yeah, and RSV. And then you think, I'm not a pediatrician, but we think about our kids. And I remember, and I'm sure you remember, I bring my kids in and they get like 7 vaccines in one day. Yeah. And I kind of can't believe I let that happen.
I know, and I look back, like I think about all those vaccines that my daughter got and on the same day.
Right.
Yeah.
Right.
No, and it's shocking because we know that, what do vaccines do? They provoke an immune response. Yeah. That's what they're designed to do. Yeah. And yet somehow we've sort of lost sight of this idea that giving 7 shots in one day could potentially not be a good thing. And there's no reason to really do it. I mean, you could spread it out a little bit.
There is no reason. There's only one reason, and that's compensation and insurance companies.
Yeah, no, for sure. Compensation and, I guess, convenience.
Well, and efficiency for the poor pediatrician who's already overwhelmed, underpaid,
right,
and
that is true, though, right? Pediatricians are overwhelmed and underpaid, right, as are family medicine doctors,
and
internal
primary
medicine
care doctors,
primary care in general are underpaid and overwhelmed, and so it's a shame. Anyway, but to bring, the chronic illness, then I think, okay, this is all great. So all these doctors and scientists, and you and I have been invited to also be part of different, parts of programs and proceedings and webinars and stuff. But all right, but let's bring it has to apply to the patients, right? Because day after day we see patients, and just yesterday a patient said to me, is there any hope that I'm going to get better? And right, and it's those things that just sort of want to bring me to tears. And so I think about what I'm reading in the proceedings, and I think about the webinars that we're part of, and I think, yes, there is. But sometimes people don't seem to get better despite all that we do.
Right.
And I don't know how to stratify them. So I always feel like I want to give an honest answer every time a patient asks me a question. And I don't always know that honest answer for that particular patient, right? So I just try to say, yes, there is a chance you can get better. I've seen it happen. We've both gotten people better. I do think, though, what I've seen over the years is that I think forever more these patients have just, I don't know exactly the right terminology, but they have a sensitive constitution. They seem to be more, they have a lower threshold for relapse of a symptom or of a couple of symptoms. They seem to be, their bodies are hypervigilant, hyperreactive, so that any kind of stressor, external or internal, can cause maybe, a disproportionate level of symptomology. And then they get nervous that they're going to be sliding back into that chronic illness that left them basically homebound, if not bedbound.
Kind of a PTSD phenomenon.
Right. And, that's a really another good point. And I always think, I always say, not always, but I often say to patients, we're going to get you better, but at some point we're going to have to deal with the PTSD from this, right? Not now, because you're not there yet, but at some point this has changed your life forever, this experience, just this loss of years, loss of functionality, loss of quality of life, loss of productivity, has changed who you are forevermore. And so we're going to have to deal with how that's going to affect your psyche later on, but not now.
Right.
And, when I get patients better, we say we have to sort of work on this a little bit.
I think that's one of their values and the reasons they're successful, the limbic retraining programs.
Mm-hmm.
And I, as I've said previous episodes, I was initially so skeptical. I thought this, I was an eye roller to this thing. Oh, come on, you're gonna get better by thinking about it, and it is impressively successful. And I think a major reason, there's two major reasons. I think one is the PTSD, and the other is this sick syndrome that they refer to in this paper that we've referred to and discussed in the past, and it's similar to the cell danger response.
Correct.
And it's such a powerful and unsettling and revolutionary thought that we can use our brain to change our cell danger response. But it certainly looks like that's possible.
It is absolutely possible.
Yeah.
I mean, things change your brain chemistry every single day of your life, though. Right? So every experience you have changes your brain chemistry and changes the lens. Sorry. Changes the lens of which you see things through, right? It does, and usually it's very subtle that you're not even acknowledging it, like it's done subconsciously and without your involvement, basically. But our brain chemistry is regularly affected, and so, but these kinds of experiences of chronic illness, like, really does a number on your entire outlook on your life, on the world at large.
Yeah, how could it not?
And your role, and that's the other thing, your identity, like who you are in this world, like, and what your role is, and in your family, in your occupation, in the world at large. Like, it just really, it just changes everything. And that's so poignant to me when I talk to patients. Like, I often think I wish I knew you before you got sick, but then obviously why would you be talking to me? But I do think that I wish I had known my patients before they were ill. But I know them while they're ill, and very often I know them after they've gotten better. So I could see the change in that chemistry from going from ill to well.
It is overwhelming when you see them get better.
Yeah, it is overwhelming.
I got a thing in the mail this week from a patient, her graduation card and her picture, and she's all better. And it was like, oh my God.
That's so fantastic.
Yeah, it was great.
Wow. I know it's powerful when they get better. And, then the things that we have to put them through sometimes, I mean, like all the surgeries, right? So, it's hard to deal with when there are complications with these surgeries that, we've recommended because we know it's the right thing to do.
Right.
And obviously we refer to, surgeons that we're very confident in, comfortable with, and it doesn't, every surgery has a risk, every surgery, no matter what it is. And so, sometimes there are complications, and it could be hard in trying to help manage those complications, especially from remotely, and especially when you don't have any role in the hospital that they may be in to really sort of intervene and make changes to what's going on. So what they go through to try to get better sometimes sometimes it can get worse before it gets better, I think.
Yeah, no, it's amazing. And similarly, we've talked about, you and I have talked about this, how I have patients who don't get better, but they still have an amazing attitude towards life and an amazing personality. They don't give up, and they joke and laugh, and it's just amazing. I think if I was you, I don't know if I could do that.
Right. I completely agree with that. And I used to when I used to do a lot of pediatric neurology, I used to think that about the parents.
Yeah.
Like, wow, they were my idols. Like, I don't know if I would be as able, to sort of be as strong as they had been for their families, but both parents. But I feel that about my patients too. And sometimes, I don't know if you experience this, but sometimes when I hang up with a patient and they're like that, they're jovial. I react in kind, right? So like if they're just sort of relaxed and like, yeah, I'll try that, I'll try this, I'll try that, and yet I know that they can't leave their house or could barely get out of bed, yet I'm reacting to their attitude. Sometimes when I hang up with them, I feel like, was I sympathetic enough? Like, because I was just responding to their attitude, to their affect, and sometimes I feel like, okay, maybe I should recognize that they're really suffering on the inside, and maybe that's just a facade they put on, but or because they've had to, over the years,
Well, it also, I mean, yes, it could be a facade, but I think more likely it's a way that they have evolved to cope with their illness, and
Yeah,
and
it's a mechanism.
it's wonderful, I think, for them.
Yeah, but that's what
And
chronic illness
truthfully, it makes it
does.
easier for me. I
Oh,
have
for
to
sure.
admit that it's
It's
easier for me
easier.
to take care of a patient like that than somebody who's very so depressed that I can't kind of get through to them.
Right.
And that's an issue, and I feel that's a weakness on my part, but it's the way it is.
Right, and I don't think it's a weakness in your part. I think it's one of the perils of telemedicine, frankly. It's hard to connect with a patient who's in the throes of depression because of their
Right.
illness on a video.
Right.
At least I
No,
find
that's
it
true.
hard.
That's true.
And it's one of the downsides of telemedicine, frankly. There's a lot of upsides, of course, because we can help a lot more people, but it is one of the downsides is you just can't really connect with them on the level that you want to connect with them.
So I want to go back to the meeting for a
Sorry.
second. No, that's okay, and I was doing it too. So I think it was very good. I confess that when I started to read it, I thought, oh, God, I'm going to spend a half an hour to an hour reading this, and it's going to be more of the same crap. And just
That's all it took you, a half
he-
hour to an
talking
hour? It took you
I
like 4
didn't read
hours.
every single word, like, talking heads kind of thing.
Yeah.
And it wasn't. It was much,
No,
much better
it was
than that.
excellent. It was excellent, yeah.
But I also came away with it feeling like, all right, well, been there, done that. I mean, this is not news, and I'm not saying this in an immodest, arrogant, self-centered way. Nothing was new in this paper, right? And whatever, however many pages, 100 pages, and the creme de la creme of academicians and doctors and scientists, but nothing new, which makes me again raise this question of we need meetings like that, which are clinicians who see patients every day, because the reason I can say nothing new, and I know that sounds arrogant, and I don't mean it to sound that way, is because I see patients every day, and every goddamn day I am learning from these patients. Literally every day, somebody will say, well, I tried it this way instead of your way, and it worked better. Bam, and that rapid accumulation of knowledge is missing from these meetings
100%.
because they don't take care of patients. I mean, I'm not saying they don't see patients, but most of them, in fairness to their job description, it's going to be 90% academics, grant writing, publications, research, and maybe 10% in the clinic. And most of that 10% is supervising residents and fourth-year medical students. So that doesn't mean they're in the room doing the whole workup and history and everything. And again, that's fine. That's the system. But we need a similar meeting for clinicians.
Yeah, for those of us in the trenches.
Because that's how you
We have
accelerate
a lot
knowledge.
to share. I know.
And that's the reason I actually love masterminds, the listserv we talk about, because for the same reason, almost every doctor on masterminds is a full-time clinician seeing patients, and the accrual of knowledge is mind-boggling.
Oh, I love when they share tidbits.
Yes, that's what I'm talking about.
Yeah, no, absolutely. Tidbits on, like, there was a recent one on how to use very low-dose
naltrexone from
very
Dr.
low dose,
from Norman Marcus. Yeah,
right, exactly.
So, and if you
He's a
saw
great
my
pain
computer,
doctor.
so I have a big display screen, and I take all those tidbits and I copy-paste them, and I put them on those yellow stickies. So my computer screen is, it's like a joke. It's like a psychotic mind. It's all over the place, And I'm sitting there looking for it. Well, where's Norman Marcus's LDN formula?
That's one way of doing it. I've been trying to figure out how to better organize all these tidbits that I learned from the listserv. The problem is the listserv, it's not on a platform, right? So it's not widely available. You have to be invited.
Correct.
And go through an email with Dr.
But that may be part of the reason it's so incredibly valuable.
I agree. I completely agree. I love those kinds of tidbits, but you're right. It's because, and it's funny because over the years, there are days, and I know that you experience too, because this is one of the very common conversations we have. We're like, I just can't do this anymore, and it's largely because of healthcare, the system. It's so frustrating. There's so many barriers, so many obstacles, medication approval. I mean, did you know recently I was told by an insurance company that they can't approve baclofen because I haven't tried cheaper alternatives yet. And I'm like, baclofen is cheap as shit.
I know.
What are you talking about?
It's unbelievable.
What cheaper alternative should I try? Baclofen has been around for like 1 million years. Like, anyway.
And now
I
that, now that,
digress.
now the no, now the pharmacists have gotten into it, and I feel very badly for pharmacists.
So do
They're
I.
overworked,
So do I.
overwhelmed,
Another one,
mistreated,
underpaid, overwhelmed.
Okay, but
They're part of
they're
chains
driving me
now.
fucking
When we were
crazy.
young, there were like private pharmacies. Remember
Mom
that?
and pop
Mom and
pharmacies,
pop
and they would
pharmacies.
answer the phone on the
They would
first
answer the phone. They
ring.
made good money. They were
Oh
happy
my
to
God,
be
it
there.
was such a
Now
different
they're
life.
miserable. Now they're miserable.
Right.
They're all miserable.
So the latest thing with pharmacists, and I don't really want to be mad at them, but I'm furious. Okay, is patient after patient, I get an email from the pharmacist. Patient requests 90-day prescription. Well, first of all, the patient doesn't request it. I've asked, and they look at me like, "Are you crazy? I didn't ask for that." And the pharmacist wants it, and I purposely don't do it because number one, it's a new medicine. I don't know if they'll
Right, and
stay
then
on
it's
it.
a waste of.
It may be a waste of money,
Yeah.
and they'll be off of it in 1 week, or it's dangerous, and I need labs. It gets me crazy.
I know.
And then the other thing, all of a sudden, I can't write prescriptions that say take 1 PRN, meaning as needed.
I know.
Who ever heard of such a thing? You can't write
can't.
that, and the pharmacy says, "Oh, the insurance won't cover it." That's like insane.
It is insane. I'm not even sure it's true, frankly.
I don't
just
think
don't
it's
think
true. I
like to
think they
fill it
make
that
things
way. And by
up.
the way, I'm really against this 90-day thing because I don't know if you know this, but in my previous life, when I was getting my PhD, I taught, my whole dissertation was on pharmaceutical residues in the environment, and I wrote a bunch of papers.
Perfect, right.
During that
Right.
time. One of the papers was about low-dose prescribing so that we don't have to dump excessive
Exactly.
medications into the
Exactly.
environment. I was on top of that world, and I was actually part of the whole take back, your medication. Most cities in the country have like a day where there's like a take back your medications day where people can bring their excess medications to the pharmacies. That was my previous world.
Right.
And so to give patients 90 days when I think they
Well,
might be on it for 3
and
days.
the joke is that
insane.
we physicians are constantly
I know.
criticized for overprescribing antibiotics, overprescribing these drugs, overprescribing those, and now all they want is 90-day prescriptions, and on top of that, they put you and I and all our colleagues through this idea that, well, what's been tried and failed? You can't have baclofen
know.
until you've tried
Something
hot
cheaper.
water
That was
and a
literally
hot
what
tub.
They wrote.
It's like
Something
crazy.
cheaper.
Yeah. It's just
Yeah.
All right. I
All right,
don't know
so
how
we
we
got
got
off
into
on a
this. Yeah,
tangent.
sorry.
But what I was saying was, on those days when I feel like I just cannot do it anymore, I realize like how much value there is in seeing patients. Just sort of
Right.
getting back to what you were
Right.
saying, and that's because what we learn on a daily basis from our patients and what we're able to share with other doctors who are seeing patients every day or most days of the week, and the give and take about, oh, have you tried this? Because I tried this on this patient and this worked.
Right.
I tried this on that patient and it didn't work. Like that kind of back and forth with other physicians who are seeing patients and just what we learn from our patients every day. Because you're right, patients share with me like, yeah, well, I felt like I should just try it like this, and I did, and it seemed to work better than how the SIG you
Yeah,
prescribed.
yeah.
Which I'm like, great. As long as these are safe drugs, I actually tell patients like, try it your way. Like, I give you permission because you can't really go wrong with this drug.
Well, and I think again, we learn so much from our patients, and the more we listen to them and the more we ask questions, the more we can learn.
That's right. And
it's
that's of great value that there aren't big enough meetings, I should say. They're small, like like WECOs, webinars and echo.
I like WECOs. It's right up there with Long Lime, WECOs.
I was thinking of the Echo series that we're part of about fatiguing illnesses.
Right.
And then I also was thinking of webinars, so I said WECO. But anyway, I think those are really great platforms, but they're not big enough, right? And I think we need large meetings like this one, right, where we bring together at least the majority of people who are doing nothing but seeing or not nothing, but mainly seeing patients is like their primary
Well, and
goal.
to be clear, the purpose of the meeting is not to pat ourselves on the back. It's to accelerate the acquisition of the
Yes.
experience and
Yes.
knowledge that has been gained in one-on-one care of
Right.
patients 24 hours a day.
And it's also not only about what we use and what works and what doesn't work, but even about what the patients tell us with regards to their symptomology, to the signs that we find on exam, to some of the biomarkers that we regularly pick up on that no one's really talking about, to even some of the unusual imaging that we find that we can't really explain. It doesn't fit into a box. Just to sort of share all of that kind of knowledge. I mean, I think that's incredibly important.
Yeah.
And so, I mean, I can give you lots of examples of things that I'm like, wow, like even on my EDS patients, we're constantly seeing loss of the cervical lordosis, right? And seeing straightening of the cervical spine. In the past year or so, though, there have been over a handful of patients that have had excessive curve to their spine that basically creates this burden of spondylolisthesis, and no one really talks about this. And I wonder how that contributes to further spinal manifestations, or even things like, disc herniations and nerve impingements and autonomic dysfunction because of the cervical spine and some of the parasympathetic fibers that run through the cord. And so, but we don't really talk. There's no forum that I have to say, hey, what do you guys think about this, right? And that's what I want. That's what I miss. That's what I love. And you obviously, when we worked in hospitals, you had a lot of that, but more in like the conventional diagnoses, not in this sort of this, very unclear chronic illness world. And I think that that's what we need. We need these big meetings where we can all just sort of present like unusual findings or like tidbits that we learned.
It doesn't have to be big meetings.
But the small meetings don't really get us anywhere. We need big meetings where there's proceedings like this that are written up, that are 150
well, I was just
pages, 137 pages.
It can be small meetings and still be written up. I mean, back in my HIV days, when we knew shit about HIV and it was just a nightmare, in New York, there was a group of about 30 physicians that met every week, basically to say, well, did you try this? And I have this problem. What do you think we should do? And it's a similar model to we've been talking about. The rate at which we develop knowledge and treatment interventions, even though we didn't know the fancy academic research science, because nobody did, was huge. I mean, I'd like to think that we prolonged lives and maybe even saved some lives until the real drugs came along so we could get the patients better. So the small groups can be very powerful, but I agree with you. We need the bigger meetings.
I like
the bigger
bigger
groups,
meetings because I agree with you, and I think a lot of small groups would be fine, but I think a large meeting can really accelerate this because, the more people you get in a room, the more chance there is that I say, hey, this patient wakes up every morning with like chest congestion, but sits up and it resolves. And then, if there's 100 people in the room, chances are that 10 people in that room had heard that before.
But that also gets to the structure of the meetings. Okay.
True.
So, I mean, no, wait, well, let me finish. I agree with you, but I would want to take it a step further. Okay. And I have this experience even when we go to our mast cell meeting. Okay.
Right.
Most meetings in medicine, including the kind we're trying to talk about, are structured or designed such as somebody gets up, they have a PowerPoint, and they flash up a dozen slides or 3 dozen slides, and then there's 5 minutes for question and answer. I think there's enormous value in terms of exactly what we're discussing and you're talking about, to change that model and say, all right, here's a case. I don't know what to do. And the presentation takes 7 minutes, and there's 5 slides and a bunch of labs and stuff like that. And then you open the floor to get thoughts, questions, answers, suggestions, et cetera. And I think that's enormous learning potential. And it happens a little bit on Masterminds, but having a meeting like that would be incredible, I think.
I completely agree. And maybe the mast cell meeting is sort of what will, I didn't go last year, so I don't have that fresh in my mind, but I'm going to go this year because it's here.
Nearby.
So I'm definitely going to go, and I think that meeting will definitely be what I'm referring to.
Right,
for sure.
I agree.
So I'm excited about that. But yeah, I agree. I think that these meetings need to include at least a certain percentage of doctors who see a lot of these patients, because the information that we could contribute is invaluable to furthering the research on how to help get these patients better, because we have to help them get them better. We have to figure out what works for any individual patient, and that's the other thing, by the way. And nothing works for everyone.
Yeah, sure.
So figure out what constellation of symptoms, signs, biomarkers, what have you, seems to respond best to this treatment regimen.
Right. So what we're talking about is the potential impact of more involvement of full-time clinicians in acquisition of science and knowledge. Okay. So another example to me of that is in this summary you sent me, which let's call it 100 pages. Okay. Literally somewhere around page 75, after the first 75 pages, somebody mentions low-dose naltrexone. Yeah. It took 75 pages to get to a drug that I use every single day in my first visit with every patient, and most other doctors do. And the efficacy of that drug is, I can't even put it into words how well it can work, not in every patient, not all the time, but to an enormous degree. And yet it took 75 pages for it to even be mentioned in passing. Okay? And again, I'm not trying to, I know I'm sounding critical of the people in the meeting, and I don't mean to be. I just mean they don't do what we do.
Right.
And therefore they don't get that rapid experience and knowledge.
Exactly.
You
They're
know?
not regularly prescribing it as we are.
Right.
And hearing the feedback from
The
patients.
feedback.
And I always
That's
tell
the key
patients,
piece, the feedback.
I always say, I'm going to prescribe these drugs for you. I want to hear. That's an appropriate use of the portal. I want to hear how you're doing.
Yeah,
You know,
that's a great
I want to
use.
hear how you're responding. I want to hear if you've made any changes. And then let's have a follow-up at a certain period of time. So we
another
go over.
great example. Yesterday, had a patient. I'm prescribing rapamycin pretty frequently these days, okay? So the general prescription is tapering up to 6 milligrams once a week. Well, we'll talk about this in some other episode. And I'm always afraid the patient will think once a day. So I say it over and over. And I heard from a patient that the patient was taking 3 milligrams daily as part of her taper. I said, did you really say that? This is in the portal. And the patient said, yes, it's 3 milligrams every day. And I went crazy. I said, no, it's not. Stop. You have to stop. We have to get labs and make sure everything's okay because there's some risk. So the patient made the appropriate changes and now is on weekly. And I had an appointment with her yesterday, and the patient said, all right, I'm doing what you said. I've tapered up to 4 milligrams a week, but I have to tell you, I felt better and had more benefit on the 3 milligrams daily.
Oh, wow.
And I've had the same experience with 2 other patients who misunderstood and didn't taper up, but stayed on 1 milligram daily. So the point here is we don't really understand how to use rapamycin, and the only way we'll learn is on literally day-to-day discussions,
Yes.
feedback with patients. And to me, it was such a perfect example of what we're trying to describe here and discuss.
Right, because we're using it for different indications. And
Right.
so that's really important.
Which is
So
every drug we use is off-label.
every drug. I know. No, that's so true. And that kind of feedback is really invaluable. And actually, I'm glad that you shared that with me because I haven't had a patient take it daily. And so that's sort of interesting.
Yeah,
I'm wondering if
I'm
change.
still not going to do 3 milligrams daily
No,
because I'm
that's
afraid.
a lot.
But
Yeah,
but I am starting to use 1 milligram daily with some patients to see. Just because, in fact, the Joan Manick study, the one that kind of made this take off,
Right.
she had 3 groups. So the 2 groups that had equal efficacy, equal lack of adverse effects were 5 milligrams a week and 1 milligram daily. So it makes sense that may work and be just as good.
Well, that is really food for thought because then I might change. And why does it have to be daily versus weekly? Can't we just do something in the middle?
Well, yeah, but we don't know. That's the whole. I mean, it is literally trial and error.
Everything we do is trial and error, though, right? I mean, even like, for example, low-dose naltrexone causes nightmares in some of my patients, so then I move it to the morning.
Right.
So it doesn't affect their sleep.
And back to rapamycin. So you're right in terms of the why is it once a week or every day? It could. So the half-life of rapamycin is about 65 hours.
Mm-hmm.
So why not do it every 3rd day?
Right. Exactly.
I mean, and there's
Let's make
pluses
it up
and
as we
minuses.
go along.
Well, I mean, you want to try to do it based on the pharmacology and the
No, of course. No, I know,
pharmacokinetics and the
absolutely.
receptors and all that razzle-dazzle, which I think is very important in this use of this drug. But at the end of the day, we're not sure. Just like when we talk about pharmacogenomics,
I was just
in
gonna
the
say that. I
enzyme,
was gonna
the
bring that up.
CYP, CYP450 constellation of enzymes in the liver that metabolize drugs. So when you get into that, if you run a pharmacogenomic panel and then you see the effects on the drugs, that doesn't mean it's going to be exactly what it says.
Right.
It's still different in every person. And then you have to deal with drug interactions. So there's no way to make it simple, and I think the only way to make it work is constant back and forth feedback.
Constant back and forth, and also I really do believe in a comprehensive workup, including genetics and not only mutations but polymorphisms, which is what pharmacogenomics sort of focuses in on. I think that what has been clear to me over my years in medicine is that every person is very individual.
Right.
And while obviously a lot of us are, most of us are the same in the ways that matter in the world, frankly. But in terms of illness and treating these uncertain, complex, chronic illnesses, I think learning as many details about a particular patient's physiology and genetics can really help tailor a program. And I've really sort of embraced that, actually, and I do quite a bit of a workup on most patients. Obviously, a lot of these things are out of pocket, so sometimes, like financial factors play a role, and I have to sort of pick and choose. But when I really like a comprehensive workup because it really gives me insight into this particular patient, and it gives me ideas that I might not have for another patient. And so I do believe, and these days, like for long COVID, like I'm doing all of it. I'm doing genetic workups. I'm doing obviously lots of labs. I mean, the labs that we've done for MECFS, though, I've added a bunch of things to long COVID because there seems to be a greater incidence of like sudden death and heart attacks and strokes and hemorrhage even. And so I've added some additional things on COVID, LPs, muscle biopsies, EMGs, skin biopsies. I do as many procedures as I could do to try to gain more information, and I think that really, really does help because I'm finding things, but I'm just one person,
Right.
and I don't do it often enough where I'm like gathering large amounts of data to really make any kind of definitive conclusions on anything. But again, another reason why I want other doctors who are doing what we do to sort of get in a room together
Right.
and really share this
Well,
information.
one of the problems is how to disseminate that information. So
Right, and I know
you know,
everyone
on,
talks that I should publish.
right, I was just going
Who
to
has
say.
time?
So
That's the other
Larry,
thing, by the way. I know Larry loves to say
he
we should
loves
be
to say
publishing.
publish, but I'm just one doctor. I already
Exactly.
work really hard, and if I
Right.
try to publish, that means I can't see patients.
That's exactly
And
right.
honestly, I'd much rather see a patient.
No, I completely agree. I mean, you're absolutely right. I mean, I used to write papers. I don't anymore because I just don't have the time.
Yeah.
We're both part of different groups and projects, that are, and so in addition to wanting to see lots of patients, and, we both have, we have wait lists of patients, and I want to help people. So I have, at some point you have to make decisions
Right.
like what you want to spend your time
Right.
doing. And while I agree that getting the knowledge out there is critical and important, I just don't have the time, and I feel like I'd rather just help patients. I really would, because I don't like to see people suffering needlessly.
Right.
And I'm not saying that I help them all, because I don't, and that's very distressing to me. But I feel like I need to at least give it a try.
Right.
So
No, I agree.
Yeah. So
one solution I've thought of is a twist on the idea of a scribe. So a scribe
right.
is, just for people that might not know, in medicine there was a whole big thing about a scribe would follow a doctor around, and that person, the scribe, would write down the notes so the doctor would be free to talk and listen, etc. Personally, I find that very strange, but I know it's done a lot.
It is.
I don't think it will be done as much now because of recordings and AI and everything else. But I have wondered about the scribe concept so that that person can write the paper, right? Let them shadow you and me and Tanya Dempsey and Bellachetta and all these other doctors that are doing this work, and put it into publishable papers that consolidate some of this knowledge.
No, that's a really good idea. I mean, they'd have to do a literature review. I think that's the most time-consuming part. I can easily write up what I see, what I know, a patient story. That would take me no time. It's the literature review that is required for a good paper, right? To sort of bring in what people have already published and build upon that.
Yeah, it's daunting.
Yeah,
It's
I don't
totally
have the
daunting.
time.
No.
I just don't have the time. And so, in fact, several people have said, because I'm so well known in the EDS world, like that I haven't published much on EDS. And I always explain, one, it's a time issue, as we just sort of said. But two, EDS is complicated. And what I work on is not just because they have EDS, it's because of all the comorbid diagnoses. And I have published a little bit. I've been not alone, I've been part of groups that have published on some of these septad diagnoses, so I have been part of that world, and I give a lot of talks on, EDS, and, and actually someone recently said to me that some of my slideshows can be easily turned into a paper, which I realize is true. And so I probably am going to try to do that a little bit because I've already done the work for the slideshow itself. So anyway, my point being is that I just don't have the time.
Right, and it's I was going to say scary, but that's not the right word. It's concerning that the amount of knowledge that isn't published and therefore is supposedly lost is huge.
Right.
And part of the problem is that medicine, for very good reasons, but also some not very good reasons, entirely is dependent on published papers.
Correct.
Day after day after day, you'll say, as shown in the literature, on this peer-reviewed this, and in this peer-reviewed that. But that means only those people who had the time or took the time or were academics, so they were paid for their time, wrote the papers, and the stuff that we're talking about, and I don't just mean me or you, I mean a huge number of doctors, is lost.
Yep.
It just
that is
gets
so
lost. And it
true.
makes me wonder, is there a better way to produce a body of knowledge to make it available to the rest of the healthcare world?
That's what I want to work on. So why, right, I agree. And I think a body of, I think a website, that's what I've been trying, that's the project I've been working on, is like a website where it's just like full of resources and full of knowledge. And it's not a publication of mine, but maybe publications of others. But just like, where I can just gather all this information for people to have access to.
I mean, again, it sounds self-serving, but initially I thought Patreon, our channel, what we're doing now, would serve some of that purpose.
Yeah,
because basically
I think it
you and
does.
I decided to do this and take our time to do it in order to spread the information that we
Right.
have been learning so much, and see if we can get other doctors to look at
Right.
it, hear it, test it out, try it, give it a test drive.
Well, maybe along those lines, though, because I will say that a lot of doctors had heard about when we discussed that endotoxin hypothesis paper on
Yeah.
Parkinson's, and so maybe we actually bring up more relevant papers and discuss them
Sure.
as just sort of a regular thing that we do. I mean, we're doing the live now once a month, which I think is has been really popular, and then maybe we just sort of do more journal club kind of settings, kind of thing.
Well, yeah, and again, other ways of disseminating knowledge. So podcasts are an amazing
Yeah,
tool
I
for
really,
that,
yeah.
and they can be made more, quote, academic, and a way to share this knowledge and put it out there that would be equivalent to publishing, but the medical community won't accept that. It's not actually peer reviewed and published. So they
Right.
It's,
Well, most podcasts that are, at least in neurology, and I'm sure it applies to other specialties, but the neurology podcasts I listen to are always inviting an author of a paper
right.
to discuss the paper and discuss the study. So that's what general medical podcasts are. So that's why I think that we do more of a journal club, because we're not the author of the study, but we can discuss the paper certainly on different levels. Not only on a scientific level, but more on a layman patient level. And so maybe that's a great use of our podcast time, because that is our goal with this podcast, is to disseminate information, educate, inform, and get a national or an international dialogue going on all these chronic illnesses, because people suffer all over the world.
So one of the challenges related to what we're talking about and related to this meeting is how does change occur in medicine or in healthcare? Okay, and
Very
it's
slowly.
well demonstrated that it takes forever.
It's a paradigm shift.
I think it's 20 years is the latest statistic for something to go from research and then discovery, research, discovery, and then it works, to here's a prescription, try this in my office, and as I've said before, my favorite example of that is the H. pylori work by Marshall, and I think it was 15 years or 20 years, and basically he was laughed off the stage time and time again. I think he was actually thrown out of some of the GI organizations, but he ended up getting the Nobel Prize, and now it's routine for a physician to say, oh, could you have an H. pylori infection causing your ulcer, et cetera, et cetera. How could that have taken 20 years? It's just crazy, and it's the same thing. And that actually came up in the summary report you sent me. There was some discussion of how do we make things happen faster. And I don't have the answer to that other than more noise, more squeaky wheels.
Yeah.
I think the advocacy groups have been enormously beneficial in the same way that the HIV advocacy groups in the early days, with including civil disobedience, got the drugs done. They actually bear or should be given a huge amount of credit for the progress that was made. Same thing with the Lyme disease advocacy groups and the MECFS advocacy groups. They are very, very effective squeaky wheels, and I just hope they keep the pressure up.
I hope they do too. I think they have the ability to be that squeaky wheel for sure.
Yeah.
They have to just make their voice louder and more persistent. I think it goes up, it goes down, it goes up, it goes down. We need to keep the pressure on for real change to happen, because it's just not happening fast enough for patients. And that's very frustrating for those of us who treat these patients. So.
Well, thank you for listening. This may have been one of our more tangential, rambling, diversionary
It was therapeutic for me,
discussions.
though, to sort of talk about this
I think
with
we
you.
covered an enormous amount of
Yeah, because I just happened to have a day yesterday of patients who, were all chronically ill for a very long time, and I was just sort of feeling like I need to get you better. I need to help get you
Yeah.
better. So
No, I know
this was
the- I
actually
know
very
the
therapeutic
feeling.
for me. So this was a therapy session.
Good. And me too. And me too.
All right. Well, thanks for joining us, and keep joining us. And we appreciate your subscription, and keep writing on the Patreon page. We love suggestions, comments, complaints. Not really, but
No, complaints are good.
yeah.
You know, it's good that somebody said I don't speak loud enough. Hopefully it was better today.
I don't think it was actually.
No?
I was thinking that while you were
Oh,
talking.
no.
That I'm very loud. You're very soft,
Oh, no.
and your microphone is way
Still too
further
far away? I
Yeah.
can't
See how close
stand
mine
it.
is.
Why can't we use one of these collar things?
Oh yeah, we should get those. Yeah, Blake. All right. We'll see you next time.
All right,
Bye.
Bye.